Hello, this presentation will be on drugs for Alzheimer's disease. Alzheimer's is a degeneration of neurons. Early in the hippocampus, it affects memory. Later in the cerebral cortex, speech, perception, reasoning, and other higher functions are affected, and there is a subsequent decline in the cerebral volume of the brain. It affects the beta amyloid and um, plaques in the brain, so those are formed outside of the neurons, which is not normal. And then you have also the development of the neurofibril tangles, which form inside the neurons. So outside you have the plaque, inside you have the tangles. And those are characteristic of for Alzheimer's. So what drugs do we use for the cognitive impairment that is caused? The goal is to improve symptoms and reverse decline. At this point, we do not have a cure for Alzheimer's, of course, um, but that the goal is to develop drugs that will reverse the decline. Right now, most of the drugs will um, just slow it down, but not stop it. Also, they'll slow down the memory and cognitive decline. So there are 4 drugs that are approved for the treatment of Alzheimer's at this point. Those are your cholinesterase inhibitors, um, donepezil, galantamine, and rivastigmine, and then you have memantine is the 4th drug. With the drug therapy, the memantine is a neural receptor blocker, and the other 3 are cholinesterase inhibitors. The treatment of Alzheimer's with these drugs can yield improvement that is statistically significant but clinically marginal. It's not recommended that all patients receive these drugs because of their modest benefits. Cholinesterase inhibitors may delay or slow progression of disease but will not stop it. Drugs that block cholinergic receptors, such as first-generation antihistamines, tricyclic antidepressants, and conventional antipsychotics, can reduce a patient's response to these cholinesterase inhibitors. So you need to have a careful history of what else the patient is taking, either by the patient, if it's still possible, or the family member. Cholinesterase inhibitors are indicated for mild to moderate Alzheimer's. They prevent the breakdown of acetylcholine. They help to slow progression, and you have the 3 that are beneficial. The side effects include cholinergic effects, GI effects, which can be significant, and that's many times the reason people stop this medication because of the GI issues. There can be dizziness, headache, and bronchoconstriction. So with donepezil or Aricept, again for mild to moderate, it can also be used though for severe AD, and that's more of a recent addition. It causes reversible inhibition of the cholinesterase. That's why its effectiveness is limited. I just talked about all of the side effects. Falls and fall-related fractures are also possible, and that's a big concern for the elderly population. With the Exelon, basically the same effects. There can be significant weight loss, which again is not something that you want to see with this medication, because of course patients, as the disease progresses, don't eat well. Intensified symptoms in patients with peptic ulcer disease and with several with bradycardia, sick sinus, urinary obstruction, lung disease, falls, and the fall-related fractures again. One thing with the Exelon, it also comes as a patch, And sometimes for a patient, if they're GI issues, you can try the patch, which then of course would not affect the GI system. Um, with the Rimonel, you have the same side effect profile and the same indicators. With the memantidine, that was the first drug in a new class. It's indicated for moderate to severe AD, and it's better tolerated than the cholinesterase inhibitors. Side effects: dizziness, headache, confusion, and constipation. Other treatments for the neuropsychiatric symptoms, not for the AD itself. Um, Resperdal's been used, especially when the patient, Resperdal, Zyprexa have been used when the patient has a lot of agitation or they're having a lot of psychotic-like symptoms. So they're not schizophrenic, but they're, maybe having some visual hallucination type perceptions or delusions. You only get modest benefits, and there is a black box warning for using those medications with the patients. One of the issues for that black box is that Seroquel is often used in very small amounts, like 25 milligrams, which would not be effective for, say, a schizophrenic patient um, to help with sleep, and that is definitely frowned upon with the patient with AD. Plus, they're very sedating. That Seroquel is very sedating. The Zyprexa is very sedating. And then we're looking at, again, the fall risk issues, respiratory depression with those. So question 1 here, the patient with mild symptoms of AD is prescribed Aricept, which indicates further teaching is needed. And the answer, of course, is D. It will stop the damage. It will not. Question 2, the patient prepares to administer a cholinesterase inhibitor to the patient. Which medication would the nurse question in conjunction with that? And the answer would be B, the amitriptyline. Question 3, the patient prepares to administer memantidine or Namenda to the patient with severe AD. Which would she assess for before administering this medication? And the answer is B, the BUN and creatinine. So obviously here it is metabolized through the kidneys. All of the other, C would mean it's metabolized through the liver, and the other two would mean it has some effect on the blood. Question 4. A patient is concerned about developing AD. What should the patient include in teaching? And that is B, that there's no solid evidence to support the use of drugs, because we aren't curing the disorder or stopping the disorder. We're only slowing down the progression. And that is it for this presentation. Thank you.